Hey guys, welcome to the online world. I'm just going to go through the PowerPoints just like we would do in class. And the only difference is it's online, but now you get to repeat and watch as many times as you need to understand and learn the material. So just to recap, in EKG 1, we learned how to interpret one rhythm. You learned about 33 rhythms, and we learned how to interpret those rhythms by steps, and you had to memorize your 5 steps. You had to answer the questions and ask yourself, are they QRSs? Are they uniform? Are they matching? Are they P waves? Are they uniform and matching? What are my intervals? What is my heart rate? And so forth. So we're going to do the same thing in EKG 2. And we're going to start off in chapter 13. And how do we interpret that 12 lead? So a 12 lead is a diagnostic test. Its purpose is to identify the presence of an MI or ischemia. Remember I said in EKG 1, MI is a heart attack, and ischemia is one of your 3 I's. We have ischemia, injury, and infarction that you would learn in EKG 2. Your 12 lead is also useful in identifying arrhythmias. Remember, arrhythmia means abnormal rhythms and other conditions. And your patient is usually at rest for a 12 lead procedure. They're usually lying on their back in a supine position. So here are your 6 steps that you need to memorize. Again, just like EKG 1, you had to memorize your 5 steps. The very first step you'll notice is to interpret the basics. This is everything from EKG 1. These are your first 5 steps, all in one for your 12 lead interpretation. You need to identify the rhythm, you need to calculate the heart rate, and get the intervals. Remember, whenever we're looking at a 12 lead, when we want to interpret that rhythm, we're going to look in lead 2, the rhythm at the bottom of that 12 lead. The second step, we're going to determine the axis quadrant. This is a method of determining the mean direction of the current flow in the heart. So remember in EKG 1, remember your leads. You have lead 1, lead 2, and lead 3, AVR, AVL, and AVF. Okay, remember in those leads, if you're looking at a 12 lead, everybody is positive except for AVR and V1 because they're on the right side of the heart, whereas everybody on the left side of the heart is going to be, of the torso, is going to be positive. Okay. The third step, we're going to check for your bundle branch blocks and hemiblocks. Remember your conduction system pathway and your septum houses your bundle branches. We're going to look at blocks that can occur there. The fourth step, we're going to look at ventricular hypertrophy. And notice we're going to be using specific leads to figure out whether or not we have these. The fifth step, we're going to determine miscellaneous effects. And then the very last step, we're going to determine if we have an MI or ischemia. Again, that's 2 of your 3 I's. You have injury, infarction, and ischemia. Make sure you write these down on a note card or on a sheet of paper. For me, I'm a writer. I have to read it and write it, and then I'll know it versus studying and memorizing the material. All right, so here's your beautiful 12 lead. You'll notice, remember, I had asked y'all in EKG 1, you need to know how to draw it. Your first 3 is leads 1, lead 2, lead 3, AVR, AVL, AVF, V1, V2, V3, V5, V4, 5, and 6. And notice everybody is positive except for AVR and V1. You'll also notice V2 is negative, but remember, between V1 and V6, I need to start negative and wind up positive. And somewhere in between, I need to be isoelectric. In this case, V3 and V4 are isoelectric. If I have a 12 lead and my QRSs are normal, all my intervals check out, my first step is normal, then I am not showing any signs of an MI or any other condition. So we are going to compare the rhythms that we take on patients to what a normal rhythm should look like. So let's go ahead and practice. We're going to determine if the QRS morphologies are normal. If they are not, what is their abnormality? And by analyzing the morphology of each lead, we can get an idea of whether there's any pathology on the EKG. All right, so again, remember, visualize your 12 lead. Visualize all the boxes, and remember, lead 2 is at the very bottom. We know that everybody is positive except for AVR and V1. Again, they're on the right side. Think of those electrodes where they're at on the body. Think about the pole that they're going to and from to give you that positive, negative deflection of the QRS. And remember, your QRS is representative of your ventricles. So here we're going to look in lead 1, 2, and 3. We are positive. AVR, we're negative. We're positive in AVL, AVF. And then we're negative in V1 and V2. We become isoelectric in 3 and 4 and positive in 5 and 6. So based on our rules, everybody is positive except for AVR and V1. So the morphology of our QRS is here. We are normal. Just put normal. Okay. Practice number 2. Again, we need to be positive everywhere except for AVR and V1 and V2. So, lead 1, we're correct. But leads 2 and lead 3, we are what? We're negative. AVR, we're supposed to be negative. AVL, we're positive. But are we supposed to be negative in AVF? We should be negative here and wind up positive here. So even though we are still a little negative, more negative in V3 than we would like to be, we still see that change, the isoelectric change going on, and we wind up positive. So this we would be, in this morphology, practice number 2, we would be abnormal. Again, we need to be positive everywhere except for AVR and V1. So here, we're negative there, we shouldn't be. We're positive here, we should be negative. We're negative here, we should be positive. And we are positive here where we should be negative. And then look over here, we should be positive here. So we are abnormal. I'll let you do that one on your own. All right, the next section, question number 2 that we're going to ask ourselves is, what is the axis quadrant? The axis quadrant is an electrical axis. It is the method of determining the direction of the heart's electrical current flow. The normal heart current starts in the sinus node, the top right of the heart, and travels toward the left ventricle, the bottom left. Axis deviation is a current that travels in an abnormal direction. So what is axis deviation? It is the current that travels in an abnormal direction. You need to know that. What can cause us to have an axis deviation, an abnormal axis? A normal variant can cause it. The abnormal axis may be abnormal for some people for no reason. A heart attack can cause it. It can be infarcted, that's one of your eyes, dead tissue that does not conduct the electrical current. Remember in EKG 1 I told you put a rubber band on your finger and it starts to turn blue. Can you still save that finger? Yes, you can take that rubber band off and save that finger. But if you leave that rubber band on for days, your finger's going to turn black. Is any blood flow going to get to there? No, it's the same thing with the heart. If our heart is infarcted, it is dead tissue and the current is not getting to it. Ventricular hypertrophy can cause an axis deviation. Arrhythmias can cause axis deviation. Remember, what is an arrhythmia? An abnormal rhythm. Advanced pregnancy and obesity can cause it because the stomach is physically pushing the diaphragm up, causing an upward axis. Chronic lung disease and pulmonary embolus, it is a rightward shift because they enlarge the right ventricle. Hemiblocks can also cause an axis deviation, and this is impulses that travel in alternate direction. So, how do we determine the axis quadrant? The axis calculation is calculated requires a compass. So, axis quadrant, we're going to use a compass to determine what quadrant our axis deviation is in. It is also a hexiaxial diagram. Leads 1 and AVF are the two leads we're going to look at to determine that axis quadrant. Remember, lead 1 from right to left, and AVF is up and down. So if you imagine lead 1, my right arm to my left arm, AVF is that left leg, right? And it's going to go up and down. So to determine the axis quadrant, if my QRS in lead 1 and AVF are both positive, I am normal. They're both positive, and I'm going to fall between 0 and positive 90 degrees. So if you think lead 1, right to left arm, lead 2, AVF, top to bottom, we're going to make a compass, a hexiaxial diagram, okay? I'm going to be negative 90 degrees on top. I'm going to be positive 90 on bottom. 0 degrees over here. And we're going to have a positive, negative 180 over here. So there's my compass. So again, we have an axis quadrant. Lead 1 goes across, and AVF is up and down. We're going to look at these two leads on the 12 lead and determine what axis we are in. If I have a positive axis in lead 1 and a positive QRS in lead 1 and a positive QRS in AVF, I am normal. I am also in between 0 and 90 degrees. If my QRS in lead 1 and AVF are both negative, I am indeterminate. And I am between the negative 90. I'm sorry, did I do that wrong? Let me double check. Yeah, that's right. I was reading it wrong. I am in between the, no, that's wrong. Indeterminate should be between the negative 90 and the positive and negative 180. That is a typo. If I am indeterminate, I am in between the negative 90 and the positive negative 180. This should be negative, okay? Not positive, okay? So I am indeterminate between negative 90 and 180 if I am negative on both sides. If I am positive in lead 1 but negative in AVF, I am left axis deviation, and I am in between 0 and negative 90. So if I am positive in lead 1, negative in AVF, LAD, I'm in between 0 and negative 90. And if I am negative, then positive, so I'm negative in lead 1 and positive in AVF, I have right axis deviation. And you'll see all this on the next slide. And I am in between positive 90 and negative 180. So that is another typo. And there's your compass, your hexiaxial diagram, your 4 quadrants. And we're looking at the morphology of the QRSs in lead 1 and AVF. Make sure you memorize those. It's just going to get harder. So here you go. Your negative 90 is up top, and your positive 90 is at the bottom. 0 degrees on the right, positive negative 180 degrees on the left. I am on the left side if I am over here, and I am going to be a positive then a negative. I am normal over here if I am both positive, and I am indeterminate if I am both negative over here. And if I'm a negative and then a positive, negative in lead 1, then positive in AVF, I am RAD. Okay? The best way to learn this is just to draw it out like I did for you. So how do you determine it? Again, you look at the QRSs in lead 1 and AVF. Lead 1 connects right arm to left arm, and it tells if the axis is on the right or left half of the circle. The AVF is the foot, and it tells if the axis is on the top or bottom half axis circle. So to determine the axis quadrant, again, if both leads, 1 and AVF are positive, I am normal. If lead 1 is positive, AVF is negative, I am LAD, left axis deviation. If lead 1 is negative and AVF is positive, if they're both negative, I am indeterminate. And if lead 1 is negative and AVF is positive, I am RAD. But you also need to know on the compass what degrees you're at. So if I am positive, so remember, the best way, draw that circle. I'm negative 90 up top, positive 90 on the bottom, 0, and I'm positive negative 180. I have my AVF up and down, lead 1 right to left. So if I am positive and I am normal, I am right here. I'm in between 0 and 90. If I am negative and indeterminate, I'm between negative 90 and 180. If I am positive in lead 1 but negative in AVF, I am LAD, between 0 and negative 90. And if I am negative in lead 1 but positive in AVF, I am RAD. They are the opposites. There you go. It puts it in perspective. So again, over here we're going to have positive, positive. Over here in lead 1 we had a positive, then we had a negative. But then we have 2 negatives over here, and then our RNA we had a negative, then a positive. So a way to remember this is, remember lead 1, if you were to draw your 12 lead, right? You have 1, 2, 3, AV, R, and so forth, right? What comes before AVF? Lead 1. So if I'm a positive in lead 1 and a negative in AVF, I am LAD. So you always want to look at it that way. Okay, so let's practice. The first one, I want you to pay attention to how they list these. What comes first? 1, 2, 3, AVR, AVL, AVF. Okay, what leads do we need to look at to determine the axis? Lead 1 and AVF. My QRS deflection, the morphology, the shape of my QRS. In lead 1, I am positive, but in lead AVF, I am negative. If I have a positive negative, I am LAD, and I am in between the negative 90 and 0 degrees. Okay? Again, so now they don't even tell you what you're looking at, but you know what order they go into. 1, 2, 3, AVR, AVL, AVF. What leads do we look at to determine the axis? Lead 1 and AVF. I am positive and positive, which means I am normal, which normal falls between 0 degrees and positive 90 degrees. Okay, lead 1, I am negative, AVF, negative, negative means I am indeterminate. Indeterminate, I am in between my negative 90 and my negative positive 180. Lead 1, I am positive. AVF, I am negative. If I am a positive negative, I am LAD. And then lead 1, I am negative. And AVF, I am positive. I am a negative, then a positive. Again, lead 1 and AVF, I am a RAD. And I am in between the positive 90 and the negative positive 180. Now you have your full 12 lead. So remember, we have lead 1, 2, and 3, AVR, AVL, AVF, V1, V2, V3, V4, V5, and V6. And that bottom line is going to be lead 2. The very first step of my 6 steps to interpret a 12 lead rhythm is to figure out the basics. Step number 1, which is interpret it. So you would use this bottom lead to interpret that single rhythm. The second step we're going to do for a 12 lead interpretation is figure out that axis quadrant. What leads do you look at for the axis quadrant? That's going to be lead 1, and that's going to be lead AVF. We're looking only at the QRSs. Here I am positive, and I am positive, which means I am normal. Again, lead 1 and AVF. I am positive and positive, which makes me a normal axis. Okay, moving on. Bundle branch blocks. Remember, your bundle branch blocks, they are located in your septum. We're also in the bottom ventricles of your heart, the bottom chambers of your heart. Okay, so a bundle branch block is a block in the right or left bundle branch. The impulse travels. We're talking about your conduction system, that fire. It's going to travel through a healthy bundle branch, BB, through one ventricle, and it goes slowly, cell by cell, on the affected side. It is seen only with a supraventricular rhythm, EKG1, SVT. So the only time you're going to see a bundle branch block is if we have a SVT, supraventricular rhythm. This is a ventricular rhythm that cannot exhibit bundle branch blocks. Results are going to be in a widened QRS, greater than or equal than 0.12 seconds, with characteristic QRS shape. So remember, a hint to know if your rhythm is coming from the sinus node, the atrium, the junction, or the ventricles is if we have a wide QRS ventricle, okay? Remember that from EKG1. The normal anatomy of the bundle branch block system. So you're going to have the right bundle branch, which is located on the right side of your interventricular septum. And you're going to have your left bundle branch, which is on the left side of the septum. The left branch has two divisions called fascicles. Okay, so you need to know that when we get to hemiblocks. So your bundle branches, again, we're in the ventricles, we're housed in the septum, and it is separated into right and left branches. Your right branch is in between the interventricular septum, and your left branch is on the left side of the septum, but has two divisions called fascicles. Okay, so here's your heart. Remember your conduction system, we had your SA node, your AV node, and your ventricles. Remember how many beats per minute? So here we have our AV node. And where is our bundle branch located? Right here, the interventricular septum. It's going to separate. My left side is going to have two branches. These are my fascicles. But my right side is just going to have one branch. Okay, so again, we're talking about the conduction system. Here we're looking at V1, right? Right side, V1 should have what kind of QRS deflection? A negative deflection. We should start off negative in V1 and end up positive in V6. So your right bundle branch block. Your QRS complex typically starts out looking normal. The QRS has an extra R wave at the end. The second R wave is called R prime and is written with an R dash. So remember we talked about that in EKG 1, that you can have two R's and you are to number them, however many that you have. And the first one is going to be R, and then your second R is called R prime. If we notice that we have an R prime, we can assume that it could be a right bundle branch block. The block of the right bundle branch, the QRS is going to be bigger than 0.12 seconds, right? QRS wide with an RSR configuration. So remember our QRS complex, the normal configuration is going to be Q, R, then S. R is positive, Q and S is negative, but sometimes we can have a QS, or sometimes we can have an RS. Sometimes we can have an R prime. If we have an R prime, we could have a right bundle branch block. And we are going to look in V1 for a right bundle branch block. So what leads do we look at for our axis quadrant? We're going to look at leads 1 and AVF. But what lead are we going to look at for a bundle branch block? We're going to look in V1. What lead do we look at to determine the first step of 12-lead interpretation? Lead 2. Also, your T wave is going to slope opposite. You need to know this. Your T wave will slope opposite of your QRS. So if I have a positive QRS, my T wave is going to be negative. If I have a negative QS, my P wave is going to be positive. So I am opposite. So if I have an R prime and my T wave is opposite of my QRS, I could have a right bundle branch block. Make sure you write that down and know that. Again, if my T wave is opposite of my QRS and I have an R prime, I could have an indication of a right bundle branch block, an RBBB. Okay, and this is what it looks like. Here we have a very short R. We come down, Q, R prime. How do you determine, how can I tell that I have two R's here? We're going to look at the line right here, your baseline. This is actually your segment. Sorry, I had a freeze for a second. We're going to look at that segment. When does it change? And what kind of deflection do we see, a positive or a negative? So when it becomes positive, that is an R. And when my first negative is going to be Q, S, and here's R prime. And then my T wave is opposite. Okay, so two rules, right bundle branch blocks. I'm going to look in V1. If I have R prime and my T is opposite of my Q or S, I could have an indication of a right bundle branch block. Okay, so again, what lead am I going to look at to determine if I have a block? So I know it's really hard to see that, but if you know your outline, you know we're going to start with lead 1, 2, and 3. AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. And at the very bottom is lead 2. So step number 1, I am going to use which lead of my 12 lead? Lead 2. Step number 2, determine the axis quadrant. What leads am I going to use? 1 and AVF. Step number 3, determine if I have a bundle branch block. I'm going to look at V1. What am I looking at? The QRSs. Do I have an R prime, or is my T wave opposite from my QRS? In this case, it is. Would be a bundle branch block. Note the RSR. So you see, it's very hard to see, but we kind of come up a little, come down, and we have an RSR. Okay, moving on. Hang in there. We'll get through this and we'll stop for a second. Your bundle branch blocks. The left bundle branch block can occur in two ways. Remember, my left bundle branch has two fascicles coming off of it. My right did not. Left bundle branch has two fascicles coming off of it. It can occur in two ways. The block of the left common bundle branch or a block in your fascicles. In either case, depolarization. Remember, what is depolarization? Contraction, right? The exchange, your sodium-potassium pump, the spark, the ignition, the electricity, the fire. Depolarization of the septum cannot occur. So if I have a block in my left bundle branch block or a block in one of my fascicles, can that septum depolarize and contract? No, it cannot. Your QRS is going to be wide, greater than 0.12 seconds, when you're going to have the wide QS or an RS configuration. Your T wave, again, is going to be opposite of your QRS. So now we're not even going to have, we might have an RS, but we're not even going to have a complete complex, a QRS. You're either just going to have a QS, QS, or you're going to have a RS. Okay? And this is going to be your left bundle branch block. If we have a left bundle branch block, can our septum depolarize? No, it cannot. What's eventually going to happen to the tissue of the heart? It's going to become an injury, ischemic injury, and eventually infarct, which is when your tissue turns black. Once it dies, can an electrical impulse get through? No. If we have that tissue, we can have a MI, a heart attack. All right, this is just showing you in perspective. Again, look, my T wave is opposite of my QS. So right bundle branch block in V1, we're going to have R prime, and our T is going to be opposite of our QRS. If it's a left bundle branch block, we're going to look at V1. We're going to have a QS or an RS. T wave will be opposite. So again, V1, you can see we do not have an R, and my T wave is opposite. This would be a left bundle branch block. Bundle branch blocks are seen only at certain heart rates. The rate at which the bundle branch block appears is called a critical rate. This is going to be a test question, your national certification. The rate at which that bundle branch block appears is known as its critical rate. Conduction through the bundle branch is normal at heart rates below the critical rate. Once the critical rate is reached, one of the bundle branches becomes incapable of depolarizing rapidly enough to allow normal conduction, and then we get a bundle branch block. The bundle branch disappears when the heart rate fails below critical rates. So we have a very small time frame to see a bundle branch block. All right, this is just putting it all together for you. So right bundle branch block and left bundle branch blocks. This is question number 3 of your 6 steps and 12 lead interpretation. We're going to look at V1. If I have 2 R's, I am a right bundle branch block. If I do not have an R, or if I just have half of my complex, an RS, I am a left bundle branch block. If I'm a left bundle branch block, can my septum depolarize? No, it cannot. And also, both of these, my T waves are going to be opposite of my QRS. What can cause us to have a block? Coronary artery disease, conduction system lesion, a normal variant, right ventricular hypertrophy, congenital heart disease, and right ventricular dilation. That is for your right bundle branch block. For my left bundle branch block, it can be caused from coronary artery disease, also known as CAD. Make sure you know that abbreviation. Coronary artery disease is also known as CAD. On the national test, they will not spell it out for you. Conduction system lesion, hypertension, or an organic heart disease. All right, what are some clinical implications of my BBB? The bundle branch blocks are a symptom of impaired conduction system, right? So if I have my conduction starts up there in the sinus node and I'm traveling through and I get blocked in a branch, then I am impaired. My right branch can be seen in a normal, healthy heart, but the left branch is almost always implying cardiac disease. It is at a risk of developing severe AV blocks. Remember, SA node, AV node, and your ventricles. Our AV node, if it's blocked, is my atrium getting depolarized? Is it contracting? Is that pump going on? No. A new bundle branch block should prompt an immediate assessment of the patient. Okay, moving on. If you need to, go ahead and take a pause. It's been 38 minutes. Take a pause. That's what's great about video recordings. All right, so moving on. So now we're going to talk about our hemi blocks. So think about it. If we have bundle branches, we have right and left. My right branch is just a single branch, right? But my left branch has 2 fascicles coming off of it. This is where I can get a hemi block. So we have what's called your anterior and your posterior. Know these abbreviations, LAHB and LPHB. And LAHB is a left anterior hemiblock, and it's a result of the left axis deviation. Again, where do we look for axis deviation? What leads? Leads 1 and AVF. What lead am I looking for a bundle branch block? In V1. For my left posterior hemiblock, LPHB is going to result in a right axis deviation, RAD. So if I have a left axis deviation, I could have a left anterior hemiblock. If I have a right axis deviation, I could have a left posterior hemiblock. Make sure you know that. Very important. Okay, it gets very confusing when you start talking about LBBB, RBBB, LPHB, LAHB, RAD, LAD, normal, indeterminate. you can already see how confusing it can get. What leads do I look for axis determinant? What leads for BBBs? Your left anterior hemiblock is more common. Why? Where is it at? On the left side. Whereas my left posterior hemiblock, what side am I on? My right side. So always, who is always going to be the most common? Who's going to have that thickest wall? My left side, my left ventricle. All right, hemiblocks that occur alone are not usually clinically significant. So if I have a hemiblock that's by itself, it's not usually a significant hemiblock. It's when we're going to have what's called a I'm going to say this wrong, bifascicular block. This is when your hemiblocks occur simultaneous with a right bundle branch block. So remember, what is simultaneous meaning? At the same time. Your heart pumps at the same time. So a hemiblock that can occur simultaneously with a right bundle branch block. It can predispose the patient to an AV block. How dangerous is a block in our AV node? Is our atrium going to get that impulse? No. So this is known as your bifascicular block. When a hemiblock occurs simultaneously with a right bundle branch block. What could happen if this happens? We can predispose the patient to an AV block, which is bad. Hemiblocks cannot accompany a left bundle branch block. So this is a rule you need to know. Hemiblocks, remember we have two, anterior and posterior. Left anterior hemiblock and left posterior hemiblocks. They can only occur on a left bundle branch block. Your right bundle branch block can occur simultaneously with a hemiblock. So that means I can have a block on my right bundle branch block and I can have a hemiblock. Where is my hemiblocks? My left bundle branch block. Left anterior hemiblock or left anterior and posterior hemiblock. Very, very confusing. Make sure you understand this. Hemiblocks cannot accompany a left bundle branch block. So I can have a hemiblock with a right bundle branch block. I cannot have a hemiblock with a left bundle branch block. Know your rules. All right. Notice we have a new lead that we're going to look at. So if I am looking for a hemiblock, what leads am I going to look at? Leads 1 and lead 3. Okay. Lead 1, the first image up there you're going to see is a normal QRS in lead 1 and lead 3. The second one is showing that we have a left anterior hemiblock. And the last one is showing a left posterior hemiblock. What do you notice? If I look at my normal one up here. My QRS is positive, my T is positive. Lead 3, QRS is positive and T is positive. What are my rules about my QRS deflections? They should be positive everywhere except AVR, V1, and V2, okay? Look at my second one. What's happening? Lead 1 is still normal, but what happened to lead 3? Am I supposed to be negative? No, I'm not. And look down here. Look what happened to lead 1. I'm negative. Can I be negative in lead 1? No, only AVR and V1 and V2, not lead 1. So if I have a positive QRS in lead 1, but a negative QRS in lead 3, I am a LAHB. I have a positive QRS, then I have a negative QRS. I am a left posterior hemiblock if I have a negative QRS and then a positive QRS. Again, what leads are we looking at? Lead 1 and lead 3. Also, I want you to notice, look at your T wave. Your T is opposite of your QRS. My T here is positive, but my QRS is negative. But down here, same thing. My T wave is positive, but my QRS is negative. Almost done. Alright, so as if to make it any harder on you guys, they try to confuse you with this algorithm. Some people like it, some people don't. This is just a way to help you organize all that information in your head. Some people would rather just to memorize this algorithm and not try and memorize all those facts. It's up to you. I'm not good with algorithms, but some people they can see it and they can just fill in the blanks on their own. So in this algorithm, you're going to ask yourself, do I have a bundle branch block or a hemi block algorithm? Is the QRS bigger or greater than 0.12 seconds? If it is, it could imply that I might have a bundle branch block. What is the shape? What lead am I going to look at for bundle branch? V1. What is the shape? Do I have R prime and is my T wave opposite? Or do I have no R and my T wave is opposite? If I have R prime and my T wave is opposite, I could have a right bundle branch block. But if I have a negative QRS and T wave is opposite, I could have a left bundle branch block. But what if my QRSs are normal in V1? I could possibly not have a bundle branch block. Next thing you're going to ask, is there an axis deviation? What leads do I look for axis deviation? Remember, lead 1 and AVF. Okay, so is there an axis deviation? If so, what kind? If there is no axis deviation, then no, there is no hemi block. If there is an axis deviation, meaning my RAD was negative, then positive. I was negative in lead 1, then positive in AVF. Or if I was positive, then negative, positive in lead 1 and then negative in AVF. Then I am to ask myself, if I am RAD, is there a small r deep and a small q? And if I am an LAD, is there a small q and a big R? Whoops. And I can't go back after that. I'm sorry. So that is your algorithm. Okay? So, practice. Bundle branch blocks. Okay? What lead do I look at for a bundle branch block? I am going to look in at V1. Yes, V1. All right. And what am I looking at in V1? I am looking at my QRSs. I can already tell here in this practice, my T wave is definitely opposite than my QRS here. Okay. I also want to determine if I have a hemi block. What leads do I look at for a hemi block? Lead 1 and lead 3. Okay, so I'm almost up to my hour mark. You're to do on your own. If you have any trouble, see me in conference tomorrow or on our normal class meeting. Okay. All right, the next question. So we had the 6 questions, right? To interpret a 12 lead. The first question was, what are your basics? What lead do I look at for those basics? Lead 2 at the very bottom of your 12 lead. Your second question was, is there an axis deviation? What lead do I look at? Lead 1 and AVF. Then the next question is, do I have bundle branch blocks? I'm going to look at V1. And do I have a hemi block? I'm going to look at leads 1 and leads 3. The next question is, Do I have ventricular hypertrophy? This is excessive growth of your myocardium. Remember your layers of your heart? Endo, myo, epic, right? Outside, myo, middle, endo, inside. Do I have excessive growth of my middle heart tissue in the affected ventricle? It is usually a result of disease. Thickened tissue requires more current to depolarize and causes greater than normal amplitude of your QRS complexes, and an EKG leads over the affected ventricle. A normal QRS should be no taller than 13 mm in any lead. So what we're doing is when we're talking about no more than 13 mm, we're talking about vertical here, going up. Amplitude, remember that from EKG 1? How do we measure time? We go horizontal, we go across. And how do we measure speed? We measure the amplitude going up. So we're just going to literally count these boxes. I can clearly see one big box, which I know is 5 little boxes. And I see a second big box, which I know as 5 little boxes. So I have 10 little boxes. Normal amplitude should not be more than 13 little boxes. So we're going to look at all of these. Which one of these has a high amplitude more than 13? None of them should. But if you look at V3, it's pretty close. We have 5, 10, 11, 12 little boxes here. So it's very close to having excessive tissue. It's dangerous to have that excessive tissue because it takes more current. It takes more amplitude to depolarize that myocardium tissue in your ventricles. Remember, your ventricles has the thickest tissue because it needs to pump the blood out to the rest of the body. Okay, so here we go again. Right side, left side. Your right ventricular hypertrophy, RVH. Make sure you know these abbreviations. They will try and trick you on the test. You're going to have a tall R wave in V1, and you have a right axis deviation. Again, where do I look for RAD, right axis deviation? What leads do I look at? And you're going to have a T wave inversion. Inversion is another word of opposite or a negative. So we know our T waves should be positive, but if it's inverted, it's going to be negative. And what can cause us to have a right ventricular hypertrophy? Chronic lung disease, right ventricular, your right ventricle bulks up to push the blood into the now high pressure lung system. So notice my T wave, it's inverted, and my QRS, it's not quite past the 13 mm yet. But your QRS configuration is typical of an RVH and V1. What lead are we going to look at for ventricular hypertrophy? V1. All right, so where are we going to look? What lead? V1. Is my T wave inverted? Yes. Is my QRS tall? It's still 10 little boxes here. But this is telling us that we have a right ventricular hypertrophy. It says, note that the R wave in V1 is taller than the S wave is deep. There is a right axis deviation and T wave inversion. Again, where do we look at for our axis deviations? We would have answered this by following our 6 steps already. And we would look at lead 1 and AVF. Where do we look at for bundle branch blocks? V1. Where do we look at for hemi blocks? Lead 1 and lead 3. Where do we look for a hypertrophy? V1. See how confusing all of this can get? Make sure you study before you take that homework and that quiz. Make sure you understand this for your national certification. It's only going to get harder here on out. Make sure You're not waiting to the last minute. I cannot enforce it enough how important it is to break up this material and study. All right. So if we talked about the right side and we know my T wave is going to be inverted and my QRS is going to be tall, what about my left side? And we know we need to look at V1. For my left ventricular hypertrophy, the criteria is going to be an R wave in V5 or V6, whichever is taller, and an S wave in V1 or V2 that is greater than equal to 35. What can cause us to have an LVH? Hypertension. Your left ventricle, just like your right ventricle, it's going to bulk up to push the blood out to the body against great resistance of the abnormally high blood pressure. So if you notice, my RVH was lung disease, right? What is my LVH? Hypertension. They both are going to bulk up and push blood out against the great resistance of high blood pressure. So LVH, look at all the lanes we're going to look at. Lanes 1, AVL, V5, and V6 will have taller than normal R waves. V1 and V2 will have a deeper than normal S wave. V1, look how tall my QRS is. But also I want you to notice what's going on in my T wave. If I was a right ventricular hypertrophy, my T wave would be inverted. But in this case, is my T wave inverted? No. And my R's are extremely long, which is an indicator of left ventricular hypertrophy. Okay. All right. Again, what leads? I'm looking on the left side, right? My left side, I need to look at where do I see those tall R's? I should see them in lead 1. I should see a tall R in lead 1. I should see a tall one in AVL, V5, and V6. And then I should also see deeper than normal S waves in V1 and V2. Okay? Now, when you get used to looking at these EKGs, you know what's normal. And you know our QRSs should not be going off the chart, right? Look how close V2 and V3, look how close they are. Look at V6, how much off the chart it's almost gone. Obviously, these are all bigger than 2 boxes except for these 2 right here. But you want to also look at that S wave. What is the S wave? Remember, Q, R, S. Here is my S wave, a deeper than normal S wave. All right. If I have an EKG rhythm, a patient whose EKG is going off the chart, we may need to change the signal. We may need to change to a low voltage EKG. Some people have abnormally short waves and complexes. What can cause this? Any condition that muffles the cardiac impulse on its way to the electrodes on the skin. Examples include obesity, emphysema, myxemia, and pericardial effusion. This is our low voltage EKG. All right. Ventricular hypertrophy. What are some of the clinical implications of hypertrophy? Increased oxygen demands, an enlarged ventricle, which means excess tissue, which means more voltage to depolarize that tissue of the heart to contract. Ventricular dilation is the stretching of those myocardial fibers resulting from overfilling the ventricles of inadequate pumping of the blood can result in hypertrophy pattern on the EKG. So let's look for hypertrophy and low voltage on the following EKGs. Answers include, so we're going to determine on these next rhythms, Is it a right ventricular hypertrophy, left ventricular hypertrophy, low voltage, or normal? Remember, my right ventricular hypertrophy, my T wave is going to be inverted, but my left is going to be positive. Look how tall my R's are here, and look at my P waves. I have very, very tall R's, especially in V3, V4, V5, and my P waves are all positive. I could be at LVH. Strip number 2. Is this normal or is this a low voltage? Strip number 3. Is this normal? 4. Normal voltage. 5. Is this going to be a left side or a right side? How can you tell? You want to look at your S waves, your R waves, and your T waves, or your T's, positive or negative. If they're positive, that's going to be left. But if they're negative, they are going to be right ventricular hypertrophy. All right. Second to last question you're going to ask yourself, and this is on the end of chapter 13, is your miscellaneous effects. Your miscellaneous effects include digitalis. Digitalis is a medication given to increase the force of the myocardial contraction or to slow the heart rate in patients with a tachycardia. So we've talked about digitalis a lot, and a few of y'all have asked, what is it? It is a medication. It's either going to increase your heart contraction or it's going to slow your heart rate in patients with a tachycardia. What effects does digitalis have? We're going to talk about that ST segment. It can cause my ST segment to sag or scoop. It slows the conduction through the AV node and it prolongs your PR interval. It can cause the ST segment to change, unknown. It is seen at normal therapeutic levels of digitalis. It does not imply digitalis toxicity. Toxicity is it's too high of a dose. So notice, remember your rules. We have your P, and this is your segment in between your P and your QRS, your ST segment. The line in front of your P, that is your baseline. But when we're looking at a rhythm, if I am in between the P wave and the QRS, I am the ST segment. And if I'm in between the QRS and the T wave, I'm sorry, y'all, I totally said that wrong. P wave, PR segment is going to be in between your PR and your QRS, and the segment in between your QRS and your T wave is your ST segment. Oh my gosh. Notice, look at my segment. Did I go back to my baseline? No, I'm doing what? I am sagging. This can be caused by digitalis. All right. Another effect is called your electrolyte abnormalities. Okay, phlebotomy students, we talked about this. This is where another part where EKG kind of comes together with phlebotomy. We have your hypers and your hypos. Hyperkalemia is going to be excessive potassium in the bloodstream. Your potassium level is going to be higher than 6, and you're going to have tall, pointy T waves. Your potassium is going to be higher than 8, and you're going to have wide QRSs. The cardiac arrest may be imminent if the potassium level is not lowered quickly. So if I have very high potassium and I have greater than 6, I'm going to have tall pointy waves. But if my potassium is greater than 8, not only are my T waves going to be pointy and tall, my QRS is going to be wide. QRS ventricles, right? If I have a wide QRS, is that dangerous? Yes. And in this case, with high potassium and a wide QRS, it can lead to cardiac arrest. Okay, so here in A, I just have a tall T wave, but my QRS is fairly normal. I am greater than 6. But look in B. My T wave is still tall, but look how wide my QRS is. I have a potassium level greater than 8. So phlebotomy, we draw blood to get your levels, how much potassium do you have? We can tell this just by looking at an EKG rhythm. We can tell more than just whether or not the patient is having a heart attack. We can tell by looking very quickly versus waiting on their blood work that their potassium is really high, and if we don't get it low, they can go into cardiac arrest. All right, so so if we have hyperkalemia, right? Hyperkalemia, then it's natural that we're going to have hypokalemia. Medical terminology, right? Means my potassium's low in the bloodstream. This is where we're going to see that very rare U wave. It's going to have, your T wave is going to be flat. This can cause a change in your EKG, your repolarization abnormalities from potassium or deficient. Okay, so remember how rare that U is? Now you can connect, when you do see that U, it could mean that that patient has hypokalemia, means there's a deficit. They don't have enough potassium in their system. My T waves are going to flatten and I am going to see a U, hypokalemia. So hyper, too much in my system. Hypo, too little in my system. And kalemia is K-A-L-E-M. We're talking about potassium. You can get these really confused with the next two electrolyte abnormalities, which are hypercalcemia, which is really easy, calcemia, and hypocalcemia. If I have too much calcium in my bloodstream, I'm hyper. If I have too little, I'm hypo. My ST segment is going to be short, and it's going to cause my QT interval to be short. My T wave is going to seem to be almost on top of my QRS, and this can cause a shortened repolarization phase. So notice my ST segment, very short now compared to the potassium, right? It's sagged for the potassium. Now it's become very short. For digitalis, it's sagged. Now it's become very short and almost on top of my QRS, meaning I have too much calcium. Hypocalcium means I have too little. I'm going to have a prolonged repolarization. The ST segment is going to prolong my Q interval. So look how long my ST segment has been become. Remember your first degree, second degree, and third degree blocks from EKG 1? What was prolonged? That PR segment, right? The Winky Bach. Now we're talking about that ST segment. If I have a prolonged ST segment, I could have a deficit of calcium, and I don't even have to get that patient's blood work to determine that. All right, here it is all together. Very last slide. Digitalis, we're going to have the sagging of your ST segment. Hyperkalemia, T wave is tall, normal QRSs. And then we have severe hyperkalemia if I have a wide QRS associated with the tall T wave. Hypokalemia, I can now see the U wave, my T is flat. Hypercalcemia, my T wave is pretty much on top of my QRS, and hypo, I have a prolonged ST segment. Okay. All right. That was it for chapter 13. Please listen to this as many times as you need to hear it. Review, read, write, practice, take your test. Make sure you're not just taking the test, but taking them. Remember that is going to be your midterm exam questions and your final exam questions. I wish y'all luck, and I will see you all in the next Zoom conference. Bye.